Afternoon, everybody. It's really my pleasure to introduce our Past Presents seminar speaker today, Dr. Jeff Golden. Dr. Golden is currently the Vice Dean of Research and Graduate Education and Director of the Burns and Allen Research Institute at Cedars-Sinai. He actually just started this position not too long ago. He just told me 7 months ago, so this is actually a very recent history. He was previously professor of pathology at Harvard Medical School and chair of the Department of Pathology at Brigham Women's Hospital in Boston. He received his medical degree from the University of Pennsylvania and completed his residency in anatomic pathology and fellowship in neuropathology at Mass General Hospital. And that was followed by a research fellowship in the Department of Genetics at Harvard Medical School. So as the chair of pathology at the Brigham, he built a very renowned and federally funded computational pathology program and established Brigham precision medicine program as well. His research has focused on the molecular and cellular basis of neurodevelopmental disorders. And his work has been published by many leading journals, and he has impressively maintained continuous NIH funding. So I'm really glad that we have he has the time to give us a seminar today. And the title of his presentation today is The Path from Computational Pathology to Precision Medicine. Before we get started, I just want to remind people, if you have questions, you can input them into the chat box and then we can field them at the end. So without further ado, I will hand the floor over to Jeff.
Great. Can everybody hear me? Can you hear me, Eleanor?
Yeah.
Okay, great. Well, first of all, thank you very much for the kind introduction, and it's really my honor to be there. I'm only sorry that I can't be there with you in person, but hopefully at another time. Oh, whoops, that's not the first slide. Hang on. Sorry about that. As Eleanor already alluded to, I kind of have two lives. I'm a developmental neurobiologist, and that's what my primary research is. But ever since moving to the Brigham and Women's Hospital, I've had this long interest in how to better use data, essentially. And that's really what I'm going to be talking about, is how to better use data as pathologists to improve the care of the patients that we serve. And so that's kind of the scope of what I want to talk about today. And I'm going to tell you the story of kind of how I got, how we did that at the Brigham. And most of this is focused on work I've done at the Brigham. So a little bit is since then, and I'll tell you about that work. And really the goal is to give you a little bit of an idea of how I think about ultimately precision medicine. And what I want to say outright, kind of as a disclaimer, is that precision medicine means many different things to many different people. If you ask everyone on this call what precision medicine is, I don't know how many people are on the call right now or on this video presentation, looks like about 30 people, we'd probably get about 35 different answers. And so I'm just going to kind of go through how I've defined it and how I use that terminology. So the objective today is to kind of formulate a conceptual plan for what a precision medicine program might look like. Again, it's one program. That's just what it means, one program. I'm sure there are many variations, and we can talk about even at the end how we might, what's worked and what hasn't worked for us and what other people have done. I will try and summarize a little bit the value proposition that is gained from doing something like this, because it's a tremendous value proposition, and it really puts pathology at the forefront of healthcare, which is where I believe we should be. And then I'll define a couple of use cases that we've gone through that helps, I think, really solidify the value proposition in this. So what is precision medicine? Well, there's many definitions. Here's two of them. One from the NCI, which focuses on using genes and proteins to prevent, diagnose, and treat disease. This one's more cancer related, as you might expect from the NCI. The FDA has another one that basically tailoring disease prevention and treatment that takes into account people's genes, environment, and lifestyle. So I like this because it really encompasses many different aspects. And that's really what I want to think about today is the idea of taking orthogonal data types, so imaging data and patient phenotyping data and laboratory data. All of these are different kinds of data, but we need to really think about how do we integrate those and structure those together to use in healthcare. Okay, why is this not moving? So what are the different kinds of data? And I just started to allude to this, and it is clinical phenotyping. This is one of the harder data to try and use when you start trying to integrate data, because it's usually written out in paragraph form, and you have to use things like natural language processing to start categorizing and structuring that data in a way that it can be used in a relational way to things like imaging data, which has a completely different type of feature to it, whether it's radiology imaging or whether it's pathology imaging or other types of imaging. And there's all kinds of other data such as EKGs and PFTs, et cetera. And then finally, there's pathology. And when I talk about pathology, I'm not just talking about image data, but all the other data that we generate in our laboratories. And the reason we really need to think about how we use that data is that it's become overwhelming for clinicians. When I went to medical school decades ago, the volume of data that we thought about, that we just knew about, was much, much smaller. We didn't know about all the different subsets of T cells, or we didn't know about the relationship of IDH mutations to specific types of tumors. These are all, the volume of data has overwhelmed most clinicians who have a short period of time to see a patient, and yet they have to integrate in that period of time a tremendous amount of things. And just to give an idea, at the Brigham and Women's Hospital, and I'm sure it's probably similar for you there, we performed somewhere around 8 million tests a year. So we had 8 million tests that we were reporting, and one test result could be an entire genome. So I'm talking about panels and different things that are very very deep. They're not just a broad set of tests, but it's a very deep data set. And these included common laboratory tests, but also the very esoteric ones. And it's those esoteric and complex ones that clinicians have a hard time not even knowing, not just knowing even what to order, but how to interpret them, and how to interpret them in the context of everything else that they get. And they really don't have a good idea of how to do that. And they're being asked to now think about menus of tests. At the Brigham, it was over 3,000 different tests that they could order just out of our EMR. So these are all huge challenges for the clinicians, which have really puts them at a disadvantage to not only being able to order the right tests, but certainly to interpret the right tests. And this is important to think about, because somewhere between 60 and 70% of all the structured data in the electronic medical record comes from our pathology department. And it's been estimated in the literature that 70% of all medical decisions are based on a pathology result. So it can be as complex as the diagnosis of a new heart disease, for example, a cardiac myopathy, and getting the right mutation, or it can be as simple as a patient who has cancer coming in to get an infusion, and they won't start the infusion until they get their electrolytes and their blood counts back. And just to give you an idea of how deep and rich this data set is, what used to be called Partners Healthcare, which includes Mass General Hospital and Brigham and Women's Hospital, as well as 10 other community hospitals. Partners has been changed, the name's been changed now to MGB. When we switched over to Epic, which was about a decade ago, 9 years ago, we took 5 years of our data in real time, and then everything else was archived and was accessible, but in an archive. The real-time data for 5 years, and remember, this is 10 years ago, the second most common data point was a radiology report, and there were 14 million of those. In contrast, for pathology, for that same 5-year period, remember the second most common is radiology at 14 million, was pathology, and there were 500 million. So that just gives you an idea of how much is coming from pathology and why it's so important that pathology is driving this, because we really do know and understand this data better than anybody else. So what's the data that I'm talking about, and why am I talking about this? And so let me just give you a couple of examples. And this is a little bit of bringing coal to Newcastle, so I'm going to go through it relatively quickly because you all know and understand this. But I think these are quite illustrative examples, or this is an illustrative example. So this woman who, now that I'm over 52, is a young woman, had some headaches and cough, and she actually had metastases to the brain. This was diagnosed in actually in 2004. That's actually an important time when that was diagnosed, and why I picked this case, because at that time her chance of survival a year and a half was less than 1%. And median survival was really measured in weeks, not years. The course was to go on a standard therapy, but it turns out that at that time, and she did do that for a short period of time, but it progressed, her tumor progressed. But it was that year that the EGFR mutation with EGFR inhibitors, so these activating mutations in EGFR, there were inhibitors that were identified, the first one, and she went on one of those and actually did incredibly well. You can see the shrinkage of this tumor right here, down 2 years later to almost nothing. It did recur. We sequenced it again, and we found a new mutation. And there was actually a specific drug for that other mutation. And she continued, she actually lived another 4 years after this, or a total of 8 years, with a pretty good quality of life during that time. And so this is an example how the advances in pathology and molecular diagnostics have really changed how we deliver healthcare. And I use this, and again, I understand that everybody knows it, but I really want to talk about this concept of data to knowledge to information. And so if you look at, so this is our onco panel. This is a next generation sequencing panel. It's about 400, just over 450 genes that we looked at. We've been doing this since 2012, the year that year after I arrived, we started this, and we've since done about 30,000, 35,000 solid tumors, another almost 20,000 liquid tumors. And if you think about this data, in the upper left panel, that's the data. And if we just gave that picture to a clinician, they basically laugh at us because it's worthless information. There's nothing they can gain from that. If you then convert that data into information, that would be the panel on the right. And that's basically taking each of those lights, as you know, corresponds to a particular base pair. And we then can align those base pairs according to a reference genome. And when we do that, we can look for where there's gaps or whether there's mutations. And that's a tremendous amount of information about all these different variants and where there's deletions and where it might be significant or not. And again, if we gave that panel of information to our clinicians, it would be worthless. They wouldn't be able to do anything with it. But when you convert it to knowledge, so you take that data, convert it to the information, and then convert that to knowledge, then all of a sudden you know which specific genes there are and where there's variance and where those variants may be targetable. And that's really what we need to be able, as pathology, we need to be able to provide that level of information to our clinical colleagues. And that's really the concept that I started with. And in doing this 30,000 times or so, what we found is that it works. It's highly successful. We find common things commonly. And also we find a lot of things that were unexpected that allow us not only to advance things academically and write papers, but also treat things that we otherwise wouldn't have been, we would not have treated in the way we treat them today. And what this means overall is that when we use this, we gain a more precise diagnosis. We are better able to treatment stratify for these patients. We also provide access to clinical trials, to targeted therapies that are often more effective, less toxic, improve outcomes, and are more cost effective. And I just gave one example of an improved targeted therapy from a journal article a few years ago. But I can also tell you there's work from, for example, from Intermountain Health, where they looked at all patients with stage 4 cancer of all types, breast cancer, lung cancer, melanoma, colon cancer, and they then stratified them to get standard therapy or what they called precision therapy, which means they just sequenced the tumor, and if there was something targetable, they targeted it. And what they found is that it significantly reduced the cost of healthcare, not because of the cost of the drugs, which are hugely expensive, in excess of $100,000 a year, but it reduced the number of emergency room visits, the length of stay in the hospital, the number of days that those people were actually back at work. And when you factor all of that into the healthcare equation, it was a significant difference in the average cost of care for those individuals. Well, what I've been telling you about is at the molecular level, but in fact, this goes to at every level, and we really need to think about all types of pathology information. And you know, I've been working now for a while, mostly with Kun Yu, and there's a couple of his first publications down at the bottom there, looking at using AI to help us interpret biopsies. And in doing that, we are able to actually better stratify. This is some work he did on lung cancers, where he can, with very high AUCs, area under the curves, predict who's going to be a late relapse group, or ones that are going to do better for longer, and those that are rapid relapse groups. And you can take that even farther, and he can actually stratify squamous cell carcinomas of the lung versus adenocarcinomas of the lung. And he can do a better job at predicting outcome than you can by staging the tumor, by grading the tumor, and by doing this long-term survival versus short-term survival. So by taking these images, knowing that it's a certain type of cancer, putting it into an algorithm, you can actually do a better job at stratifying what's going to happen with these patients than you would with staging or with actual grading. And what we've done is actually integrated proteomics in this as well, with the idea of even gaining more insight and information so that you can take this omics data, the pathology data, integrate all of that, and provide a much better guidance for our clinical colleagues on how to stratify, diagnosis first. So sometimes we make new diagnoses, but we also are better able to predict what's going to happen with these patients and what's going to be the best course of treatment for these patients. And I've listed a number of papers that I've been involved with Kun Yu and others to actually integrate these different kinds of information. And one of the real goals is to actually do some prediction modeling. So this is work we're doing where we can actually take brain tumors that are frozen sections. So we're actually using frozen section images, and we can predict with pretty good AUCs from either the TCGA data set or from a Brigham data set where we transfer knowledge from the TCGA. We get pretty good and getting better AUCs to be able to tell the surgeon in the OR if it's a tumor with an IDH mutation or not. And they're actually changing their surgical approach based on whether it's an IDH mutation or not. So we're giving molecular data in the OR that's going to start affecting how we do the clinical work. And just if anyone's interested, I'm happy to share this afterwards. We've actually built an app to do this because our goal was that we would be able to actually provide this kind of an algorithm for institutions, hospitals, and most importantly, countries that do not have sophisticated pathology, where you can actually just take an image with an iPhone of a frozen section, and it will actually take it up to the cloud. It'll actually run it through this algorithm, and it'll actually tell you with what level of certainty that it's a certain type of cancer and the grade of that cancer. And if you scan that barcode, you will go to a beta test where you can actually try it live now. You can actually take an image out of a microscope or pull it off the web and run it through this algorithm, and it'll help you. And we'd love for you to try it to give us some more information on what's working and what's not working with this app, with the goal of doing this, being able to provide pathology services to under-resourced countries. Well, what I've told you about so far is all about cancer. And what I wanted to just remind you is this is not all about cancer. This is a prenatal example. This is actually, this woman was a nurse at the Brigham and Women's Hospital. She agreed to let me photograph her. She had a first child that had a severe malformation and died. And we, using a low-pass genomic methodology, sequencing methodology, we're able to help her recognize that she had a child, she was pregnant with a child that did not have the known mutation and actually had a very healthy child. So this is not just for tumors. This extends how we use this, what we do in pathology extends to prenatal diagnosis and really all aspects of healthcare, neurologic disorders, cardiovascular disorders, renal, et cetera. So with that in mind, I now, and again, I know that I'm kind of speaking to the converted on this in speaking to a pathology group, but I now want to take a kind of a change in pace and think about how do we get to where we can use this data? What does a system look like that allows us to integrate our pathology data in a more effective way and deliver that? And so I'm going to take a digression and talk about maps for a minute. So for those of you who are fans of Middle Earth, this is a map of Middle Earth from Tolkien's trilogy of the Ring. And what maps are really great for is seeing different terrains and getting directions. So if you need to take this ring out to where you need to have it destroyed in a volcano, you can go through and avoid the mountains and go through passes and take the fastest and easiest route. But what this map doesn't do is tell you anything about things like, where the orcs are hiding and they're going to attack you, or other treacherous things along your way. And so there are maps that do that, and Google is a great example. So this is Google Maps, and there is going to be a point to all of this, so don't fret yet. But when you think about Google Maps, it will tell you all the streets and how you get from one place to another. But one of the advantages is that you can also get traffic information. So you can tell what the best way is going to be to get somewhere. And now there's things like Waze in addition to Google that will help direct you to take that the path that will get you from one place to another in the quickest possible way. And in fact, you can map out an entire trip and it'll tell you how to go. You can put in there, you can just type into the search engine in Google and it'll tell you, you can set, oh, I want to stop after 3 hours of driving and where hotels are there. If you need gas stations, places to eat, everything along the way. It'll even link to Google Earth and you can even map out every single turn you're going to make so you have a visualization of each turn that you want to make so that you don't miss any of those turns. And what really has been the innovation by Google is that all of those things I just described are not in a single database. There's actually many, many databases that Google is drawing from to be able to create that real world experience. The ability to do things in the real world takes many, many different data sets. And each of those data sets, what makes it so valuable and how Google's been really so innovative is that they're relational to each other. So when you want to drive from one place to another, it may take the maps and it may take traffic patterns and it may take the speeds that average speeds that people take, each of those out of different data sets, and it just pulls those data sets for your specific search, and it ignores all the other data sets. So it's able to specifically vertically interrogate these different data sets. And that's really the concept that we want to get to in healthcare. And so here, the idea is that we take our clinical phenotyping, our genome, our microbiome, and we can take any number of data sets, but we don't have to have a complete data set. As a matter of fact, you can use something called synthetic data to fill in data sets as long as you have enough populated in each of these to be able to make extremely accurate predictions of what's happening in patients. And so as long as we can convert these orthogonal data types, so genomic data with patient notes, that's signs and symptoms that have to be structured, along with pharmacy data or EKG data or anything else you want to include in it, if you can structure it so that they're relational, you can then build algorithms that will vertically interrogate, just like Google does, to help you navigate your way. You can begin to really gain incredible access into understanding patients and where to go with that. So what does that look like as you build it into a healthcare system? So this is where we are currently, and we're a little bit more advanced, and I'll take you on the next slide to a little bit more advanced. But basically what happens is that a clinician will see a patient, they'll start collecting the information on their clinical exam, they'll order some laboratories, they may order some radiology, and they then have to integrate all that information themselves and make a decision on what to do. They adapt that decision and they come up with an action plan for that individual patient. And there's some things that are simple algorithms already. Think about, for today I'll use GFR. Glomerular filtration rate is not a single thing that we measure. It's actually based on a urine output with your creatinine. It's a number of different factors that go into it. And there's an algorithm that calculates GFR, and it might even be different for different populations. And so that provides some additional information to the care provider that they can't just calculate on their own. And some of these get even more sophisticated. And I already gave you an example where we take, when you think about cancer genomics, we pull from the literature and databases from external to our own institution, as well as our own sequencing, to build an algorithm to start looking and saying, oh, this particular variant is important, and this variant is a common one that we see in 80% of the population and is not important. And so that allows us to even give more information to our clinician. Again, we talked about how there's no way they could actually, if you gave them just the data, they would ever be able to use that data to be able to provide care. And ultimately, what we want to do is integrate all of this. So we want to be able to take all the different omics. We want to take our radiology and our pharmacy data, as well as external databases, and integrate all of that information to be able to provide to the care provider a far better specific set of guidelines or information that would allow them to have knowledge to be able to assist that patient. And so let me give you a couple of examples of what we've done in the past back in Boston. And so this example, I think, is a pretty illustrative one. This was done by John Higgins, who was a trainee in our department and then moved over to MGH. And he took about 10,000 patients with iron deficiency anemia, 2,000 patients with iron deficiency anemia, 10,000 results. So an average of 5 results on each patient. And he actually asked 5 different hematologists, what can you tell me about these patients with known iron deficiency anemia? And all they could really tell you is if the patient was anemic or not. And so then he trended the data, that's what you can see here. And he said, okay, here's the trends of all their CBCs. And again, all they could tell you is when that patient was anemic or not. He then went to the literature and he found that, if you look at the biconcave shape of the red blood cell and how that relates to the average life of that red blood cell and their volumes, and looked at not just 1 or 2 of these parameters, which are usually looked at, like hemoglobin and hematocrit, but all of the different parameters that you get on the red blood cells. And you build that into a mathematical model, you can actually predict with approximately 96% sensitivity and 88% specificity who is going to be anemic in 60 days, 63 to be exact when he did it. This changes how clinicians would interact with their patients completely, because all of a sudden in that population of 2,000 patients, it turns out 85% of them are very unlikely to become anemic in the next 2 months. But there's 15% that are at very high risk. And so those clinicians now are focusing on just that 15% of patients. They don't have to see 2,000 patients. They only see a subset of the patients. They have more time to spend with each patient. They know before they become anemic that they're likely to become anemic, so they can treat them with iron or EPO or a blood transfusion or however they're going to treat them, and prevent them from becoming anemic, prevent the complications of anemia, prevent them from having to go into the hospital, and keeping them productive and at work. And at the same time, for that 85% that are at very low risk, they can say, you know what, you don't need that iron right now that is going to cause you abdominal cramps and constipation and other problems. And so you can actually just come back and we'll test your blood again and we'll see if you need to be checked in the future, if you can just keep going as you are. So again, this completely changes how you think about your patients. Let me just give you one more example. We follow patients for diabetes with an A1C. And we know that if a patient has an A1C of, let's say 15, we know that their diabetes is pretty much out of control. If they have one of 2, we know that they're in pretty good control. If they come in with 8, though, it's a little bit harder to tell. Are they in control? Are they not? Are they somewhere in between? Well, it turns out we can gain much more information than that by understanding the red blood cells and the average life of red blood cells. So we're all told that in medical school, the average life of red blood cells is 120 days, but it turns out that that's different for different individuals. Some people have very high turnover rates and have average red blood cell lives of maybe only 50 days, whereas other people turn over red blood cells slower and maybe 150 days. And it turns out that significantly changes your A1C. So if you're a very rapid turnover and your A1C is 8, that's artificially lowered and your A1C is actually much higher. If you're you have a slower turnover of your red blood cells, that A1C is artificially elevated, and you're actually under much better control than you thought you were. And so we've actually begun correcting this, and it fits in all the models with understanding how patients are progressing. So again, this is taking the data we already have, combining CBCs with A1Cs and understanding how red blood cell lives are going to be able to actually gain a greater understanding of patients. And this allows us to do what we really want, which is dynamic integration, so that we take all of this information, and every time that patient's seen by a provider, we gain new information, and that feeds into our algorithm to give more and more precise information about individual patients and populations of patients. So what does that look like in a healthcare setting? And these are a couple papers that I was involved with writing a few years ago, where you take external and internal databases. So you take, the literature, 1000 genome, all these external databases. I see that this got moved over, but internal databases like our pharmacy data, clinical phenotyping, laboratory data, radiology data, and we put that into our databases, whether that's in the cloud or in a server or in a cluster, wherever it is, it's stored in, and it's structured. That's the key. It's got to be structured in a relational way. And I described what that is. And so think about having this data as those pretty little dots I showed you on the sequencing that comes off the Illumina sequencer. You have the data, and that data is worthless, as we talked about, unless we can convert that data to information. And we do that through informatics. And this is a big part of where pathology is currently involved in, is converting that data into information. But then we have to go further and do prediction modeling, set up inferences, so that we can convert that information. So again, thinking about this is the raw data. This is converting it so we know the sequence, the alignment of all that data. And then we convert that to knowledge. And that knowledge is knowing which genes are affected and being able to provide action. We need to make it actionable. We need to provide decision support and integrated reporting so that physicians, the clinicians can use it, the laboratories can use it, more and more patients want to know this information, and it'll be extremely helpful for healthcare systems in managing populations of patients. So what do you need to build to do that? And this is kind of what we've put in place that we felt you needed to build. So at the top here, I call this my pantheon with the pillars out in front. Maybe a poor example, but right now there's an electronic medical record. We're using Epic. It places an order for our lab information system. We're currently on SunQuest, but we're going to move over to Beaker. And then that information gets fed back into the EMR for the clinicians to use. And we feel that that whole thing needs to be sitting on top of a computational pathology program. And that computational pathology program really needs to consist of at least 4 different pillars. I'll start here in the center with this hardware and software. This is how we basically acquire the data, how we basically suck up all this data from all these different places, including external databases, which you can see down here. We store the data, we retrieve the data, we annotate it, we structure it, we clean the data, we make sure we can get all of that in place. That's a hardware and a big lift. That's a big part of what you need to do. There needs to be an informatics piece. This is where you convert everything to information and then into knowledge. And you do that by building algorithms, testing hypotheses, and then doing the research to be able to do that prediction modeling. And finally, and I call this my factcheck.com, you need to have appropriate biostatistics. This is an incredibly important part of this, where we have where we make sure we can build models that can tell us almost anything, but we need to make sure that we're doing this in a biologically relevant way and validating everything we do along the way as we're building these processes. And then importantly is that we have to have a knowledge pipeline. This is where we actually get this is where we make it actionable. Get it back into, use it by the computational pathology, use it by the pathology department, but also be using it by this electronic medical record, by our clinicians and by patients who gain that information out of their EMR through patient gateway or whatever the process is for your patients to see your data that is required by the common law now. So we've been working to build that, and as we built that, you know, I really considered that computational pathology, and as we were building that, the president of our organization, who at the time was Betsy Nabel, she said, well, what if we do this more broadly as for the whole institution? And so she asked me to put together a team that we would call precision medicine. Now, this is where I get in. Precision medicine means many different things to many different people. I'm not here to argue semantics. I'm just going to tell you about what we did. So we put together a team that included people from medicine. This Joe Lascalzo, the chair of medicine, worked on this with me. People from pathology. Some of you may know Lynn Bree, Levi Garraway, and Zach Cohen, people who have expertise in informatics, geneticists, and radiologists, bioinformaticians, Anthony Philippakis, and they became my steering committee. And we then set together these different groups that we needed to create expertise across the organization to be able to deliver, which we came up with this hub and spoke model, which we called our precision medicine hub. And this is really kind of like a project manager. And this project manager will input projects and then decide what needs to be brought into being used by a given project that would then allow it to be used to deliver clinical care. So in some cases, we needed to, you know, make sure we had IRBs in place. We needed often to develop new informatics pipelines. Some places we had to build databases and data warehouses. We had to have imaging. We actually, at some places, actually did lab test development. This was all what was brought together in this hub and spoke that allowed us to look at a single project and then learn from each project so that the next time a project came along, we already knew how to do things. And every project then gave us more and more information and built on itself. And there was then delivering that to clinical care. And then that in turn was fed back for what was working and what was not working. So this is the model. I'm not saying we've done it all. We have not. Some pieces are in place and working. Other pieces are still a work in progress. But let me finish by going over two projects that we did that I think actually are, again, illustrative of some of the successes. So one of them was a pulmonary precision medicine project. You can see the different people that through this precision medicine hub that this integrated. And this really was to look at interstitial and cystic lung disease. And the cool thing that came out of this was that we actually figured out using imaging, using genomic data, as well as using some pulmonary function testing and other types of testing, including a test we developed to measure some analytes in your exhaled breath. We actually were able to determine that there was a screening methodology for short telomere syndrome, and we used that actually to tailor how we do lung transplantation. There was actually two categories of patients. One that required, based on their on this algorithm, high level of immunosuppression, and another group that we did a much lower immunosuppression. And the ones that we could do that lower immunosuppression actually had fewer complications. Whereas the one, when we trialed the low immunosuppression in the other group, they got more complications. So we knew they had to be more immunosuppressed. So again, we can build these algorithms that help us understand how to care for patients. We have a pretty large lung transplant service, so we were able to do that here. So again, really leveraging where our clinical strengths are with this whole program. And the last one I'll tell you about is a C. difficile project, which I think is one of the coolest ones that we did. So Again, I'm not going to go through the details because I'm talking to probably a group that knows more about this than I do, but it is the most common nosocomial infection in the United States. C. difficile is responsible for about somewhere between $4 and $6 billion in healthcare spending due to increased days in the hospital, increased treatments, and actually morbidity and mortality. And currently, if standard antibiotic therapy is not successful, they go on to a fecal microbiota transplant. And that's successful in a relatively small additional percentage of patients. And so we kind of felt like, wow, wouldn't it be great if we could really understand this at a different level and be able to come up with a far better therapeutic option. And so we put together a team that included clinicians as well as computational modelers from the Department of Pathology, someone I hired, Georg Gerber, and then from our microbiology lab and animal modeling, which Lynn Bree runs our Notobiotics Center. And so what we did is we started collecting patients that had controls as well as first-time C. difficile infection, recurrent C. difficile infection. We then modeled that in mice, and we built a prediction modeling that I'll show you on the next slide that allowed us to go through and actually identify, whoops, I'll go, by looking at, we had to actually build an algorithm that was no longer a three-dimensional, but a four-dimensional algorithm looking at the microbiota in the gut, how it changed over time, how it changed in response to different therapies, and then looking at it in a phylogenetic tree. And when we did that over time, we actually identified one organism that when you gave that organism back to the mice, they would go from 100% dying from the C. difficile in our models, from humanized gut microbiota, adding C. difficile, they would all die, to 100% survival just by adding this one organism. We've actually taken that to large animals, have shown the same thing. And this is now, we started a small company, and this is now going into phase 1 to 1A trials. So if you take what all of this means, and let me kind of come back out from getting really into the weeds there to a specific trial, we really need to think about leveraging our health systems and really thinking about new models of healthcare delivery and how pathology in particular can support this and really provide a new way of thinking about healthcare. And if we do that, I think we can provide higher quality, safer, more efficient, certainly cost-effective patient care. We can support new ways of caring for individuals, and not just individuals, but populations. Think about the examples of diabetes and the iron deficiency anemia examples I gave, and provide better informatics support for all aspects of healthcare in terms of our mission of caring for patients. So that's the message I want to leave you with. And before I leave, and I'm happy to take questions, I just want to thank a large number of people that have done this. I've talked about the precision medicine program at the Brigham and Women's Hospital, our division of computational pathology, which has some really talented people that I was able to recruit into the program. We worked very closely with MGH and their growing group of computational pathologists, and David Lewis, who's the chair there, is I think as committed as I am to this. Brigham and Women's Pathology has a large number of people that are also interested in this topic. And I work closely, I mentioned Kun Yu from the Department of Biomedical Informatics at Harvard Medical School, and also McLean Nasrallah, who's at UPenn, who has provided some of the samples that we've been doing to make sure this is transferable to different locations. It's not just something that is at one location and you have to recreate it at every location. So with that, I'm going to end, and I think we have a little bit of time for questions, and I hope this was a valuable thing to hear for all of you. Thank you.
Great, thank you. Thank you so much, Jeff, for such a great seminar. So we do have some questions in the chat box. I can read them out to you.
Okay.
So the first one is actually from Charlie. He asks, have you or anyone else been able to use digital pathology imaging of tumors to identify mutant clones with likely different responsiveness to therapy compared to the main body of tumor?
Yeah. So Charlie, I'm glad you were able to make it. I hope you're feeling better. We have not been able to do that at a clinical level. Where we have been able to do it, and this is not my work, but work of people like Ben Ebert and others, have been able to do that in hematologic malignancies in particular, where in the laboratory, they're able to identify, using mostly single cell sequencing, clones of cells that are recognized to be resistant to standard therapies that might be given. And so that's I think that's something that's on the horizon. It certainly has been done now in the laboratory for hematologic malignancies. There's some early work in brain tumors. I haven't seen that for other tumors, although I'm guessing that work is going on and I just don't know about it. So hopefully that answered that question.
So as a follow-up to Charlie's question, it's actually a question from me. How well do the AI algorithms that you talked about that took into account of morphology features, how well do they predict molecular heterogeneity in a tumor?
Yeah. So one of the things we're doing is you can use some techniques where you actually weigh which tiles the algorithm is using and weighing most strongly to make predictions about both the histology, but also the molecular components of what it's reading as being abnormal or normal. And these tiles are fairly small. They're about the size of a lymphocyte nucleus, the tiles that we're using. And you can then use a heat map to see which tiles are being used to make the estimation of the molecular and the histologic features. And by looking at which ones they're using, you can see which parts they're not using, and you can then make predictions about the molecular heterogeneity in a tumor based on those heat maps. Now, it's not perfect, but it actually does a pretty good. Now, the only thing we've looked at so far is IDH. So qualification, we haven't looked at trying to look at other things in brain tumors like ATRX or EGFR or any of these other things. But at least for the IDH mutation, which is so important for the clinical, for making the grading diagnosis and even treatment now for brain tumors, the IDH mutation, we can actually start looking at where the algorithm's looking at the tumor and making those distinctions. It's not a perfect answer to what you just said, but it does give us insight into how to do that.
Yeah, I was also wondering about intertumoral heterogeneity or intra, or multiple metastases within the same patient. Like when you do the algorithm and say it's an IDH mutation in the primary tumor, and it evolves to take on additional mutations in other metastases, is there a way to predict that, or have you seen difference in morphology features?
Yeah, so we have not done that, so I can't answer that. I will direct you to a really interesting paper that just came out in Nature about a month ago or a month and a half ago from Faisal Mahmood, who's one of the individuals I had recruited. Faisal was able to take the histologic features and molecular features of a tumor, a metastasis of unknown origin, and he's able to predict the site of origin from just those 2 data points. And it's a really nice paper in Nature doing that. And so that's the closest I know to be able to take metastases and make predictions from it. Not quite the question you were asking.
Yeah, I read that paper. It came out in Nature recently, right?
Yeah.
Yeah.
So it's not quite heterogeneity, but it's starting to get at that question.
Exactly. Yeah. So we have a question from Brian. Really nice work. How can we tell if algorithms are reiterating or reinforcing racial biases? The EGFR calculations is a simple example of this, but more complex algorithms could end up doing similar things in a more sophisticated way.
Yeah, great question. And as probably everyone knows, there's been quite a bit of controversy of reporting the EGFR for different racial groups, and I think for some good reason there. I'm not sure I have a good answer for you, whether it's going to be doing that or not, whether it's going to be reiterating or reinforcing racial biases. What I would say is that the most important thing we can do going forward is to make sure we include diverse populations in the research that we do, so that we can accurately report things and be able to do things in a way that are going to be able to provide the best healthcare for individuals, because we do know there are population and racial differences, most of which we don't know what they are. Here in Los Angeles, we have a very large Korean population that we take care of at Cedars-Sinai. And we know that they're experiencing breast cancer at a much higher rate than we see in other populations. And we don't know why. And that's something we're looking into now. So I think we have to include all of these diverse populations in the research we're doing. So often they are not. And I think that that's going to be the only way we're going to be able to address these very challenging questions.
So the next question is from me again. It's more of a big picture question, just kind of asking you, in your experience, what are some of the major challenges that you have run into integrating multiple databases and sets of information for the purpose of improving precision medicine-based therapies, especially at an academic institution?
Yeah. So the biggest challenge I have experienced so far is silos. People not wanting to share data or doing things and then not wanting to be part of kind of the bigger effort. And this has happened, imaging often wants our pathology image data, but they're not as willing to share their image data and the analytics they're using for it. So I think silos has been one thing that has been a major problem. But the next one is the cost of the data storage. I mean, what we're talking about, if you scanning one glass slide is about the same amount of storage data as an MRI of the head. So it's a huge amount of data storage that we're talking about. We're getting into, petabytes and beyond that we are going to have to be storing. And then once you store that data, what is the capacity to be able to actually interrogate it in a reasonable time frame? Because so much data takes up so much, RAM or active memory, and the need for the right processors. You can't really use CPUs, particularly for the image data. You really have to be using GPUs, and there's just not enough of them around to be able to do it. So there's hardware, there's some software, and then there's some societal or silo types of challenges. And I would say those are the big three that I've come up against.
Yeah, they do sound very familiar.
Yeah.
the challenges. Charlie has another question. There is a developing technology of molecular imaging. It's probably at the Brigham or the Mass General that has been able to identify vascular inflammation with this approach, as an example. Do you know if these have been integrated in some way with pathology in these systems or anywhere else?
Yeah, there's a variety of different molecular imaging methodologies that are going on, as well as metabolic and proteomic imaging. There's mass spec based ones that are really quite interesting. There's now new confocal microscopy probes, so you can actually inject these fluorescent molecules into patients and use a confocal microscope that's on the end of a probe. It's a rotating confocal microscope, and you can actually image at the cellular level in vivo in a patient live. You can watch blood flow through blood vessels, and there's methods to see inflammation and other things. So there's a lot of really cool imaging technologies on the horizon. And most of these that I'm aware of are still in the research domain and have not become part of the routine clinical care. There's a few that, like PET imaging that gives you some molecular data. There's some blood flow data for MRIs and things, but most of this is in the research domain. I have not been involved in any integration of that with the other databases that we've been working on.
So we're running out of time, but the last one is also from Charlie. It's more of a comment than a question. It says the anecdote. Stanley Robbins at autopsy rounds at the Brigham also used to stun trainees by his ability to identify an unusual and unexpected metastasis of a known type and correctly suggest a site of origin. And that happened decades ago.
I guess he was a machine learning algorithm by himself.
I agree.
Yeah.
Well, I think we're out of time. I want to thank you, Jeff, again for giving us such a great seminar. Feel free to reach out to Jeff with additional questions. I wish we could have more time today, but that was a great seminar and discussion.
Great. Thank you very much. And hopefully next time we'll all be in person.
I hope so too. All right.
Okay.
See you later. Bye. Have a nice afternoon.
Bye-bye.
Bye.